Thank you, Emma, and thank you everyone for having me here. Before I start with my talk, just a couple of quick questions. How many people in the audience have been to India in the last 3 or 4 years? 3, 4, 5, 6, 7, 8 people, so half, a bit less than half. And how many people here who are students? Okay, so I'm going to try and keep it very simple, but feel free to put your hands up if you don't understand or follow anything, and I'll be very happy to stop and explain things. Okay, so we'll crack on then. So this is just some, India means different things to different people. And to some people it means things like this, like the Taj Mahal, or the Indian cricket team, or a hot spicy curry, or even Bollywood. I was about to say hot spicy dance, but that. But increasingly it means more and more things like these. For me it's about East meeting the West and old meeting the new. And in some case you end up with, I would say, some pretty effects like the one on one of the pictures here. But in other cases you end up with not so pretty effects of this East and West mixing, where you end up with what some people call the dual burden, and you have this thing between, on one hand you have this poor, starving children, undernutrition, and then this overweight and other issues that come up at this point in time. This I just put up a picture of some what the Indian cities look like right now. I think I was on the bus this morning and I asked the lady sitting next to me in the bus, I'm doing this talk, and do you think I need to bother showing pictures of Delhi or India or not? Or people already know what it looks like. She said, don't worry, we've all seen Slumdog Millionaire. That should help. So I think the point here is you've got these cities in India where you have this, what we call the old world on one side. And this is the newer world where some people live, not everybody, in these sort of high-rise buildings and these modern malls. And so this is the effect it's having on the health of the population, this change from the old world to the new world. And the thing to point out is that this slide here shows the projected causes of death between 2004 and 2030. And what you'll note here is, as I think already cardiovascular disease is now the commonest cause of death in India, and soon it will become even more common. And the other thing to remember is that you can see here that even though these conditions are becoming common, these ones, like undernutrition and infections, aren't disappearing. So what you end up with is this double burden scenario where you have within the same generation children who are both undernourished and overnourished. And that has implications, as you'll see in a minute. So what can we do about all of this? Well, that depends on what we know about these conditions, and that will help us decide where we need to go from there. Just a quick slide, and it's most directed towards students or other people who are not from the background of medicine or biology, because a lot of this talk is focused about cardiovascular disease. This is just a very simple diagram just to point out that what happens is that as we get older, our arteries tend to get a bit thicker and stiffer, and in due course they clog up and stop the blood flowing to the heart, and that can lead to what you might call as cardiovascular disease or heart attack. This normally should happen very slowly as we age, and should happen in sync with your real life, so when you are 80 or 90 or 100. But if you have all these other risk factors that are causing stress to your arteries, it's a bit like aging. So if you spend living a wild life and spending too much time outside, you start to get wrinkles quickly. The same thing happens to the arteries too. So if you don't behave well and have all the risk factors and stresses acting on your arteries start to wrinkle up and shrink up and become blocked. And so you have a heart attack much sooner in life than you ideally want it to happen. That's just by the way of background. So what do we know about these? So the idea is that if we knew a lot about these risk factors, we'd be able to do something about them, stop them stressing the heart and blood vessels, and that way prevent cardiovascular disease, which is the whole point of public health and disease prevention. So what do we know? Well, most of what we know about cardiovascular disease actually comes from a town a little bit just up north from here, in Framingham, Massachusetts. I don't know how many of you are aware, but one of the most famous epidemiological studies was conducted in this town, where they recruited a population of about 5,000 men and women in 1949 between the ages of 30 and 60. And then what they did was they carried out these 2 yearly examinations on these populations till about now, and linked them to various events and death registers. And this actually has been one of the most informative studies in trying to understand about causes of heart disease. So a lot of the information that we take for granted today in terms of risk factors like tobacco, high cholesterol, blood pressure, physical inactivity, a lot of this information actually came from the Framingham Heart Study. So this is all very helpful, but this study was done when people were between the ages of 30 and 60. So does all of the heart disease actually, or all these risk factors start when we are in the middle age? Well, apparently not, because we know from studies such as these, and this is just one of the many studies that have been conducted, many of those from the US. So a study was conducted in US Army Korean recruits in the 1950s where they carried out autopsies on the blood vessels. And what they found was that already atherosclerotic changes were happening when these people were in their early 20s. And so clearly the process was starting much before that. And there's other data from other studies from the Vietnam War veterans and even in almost newborn babies that we know that all of this starts fairly early in life. And so we don't have to wait till we are in the middle age. And the other issues are what about the antecedents of these risk factors? So it's fine that you've got high blood cholesterol is bad for you, but what causes this blood cholesterol to be raised in the first instance? Because that again is an important thing to try and understand. And that leads us to this very probably difficult to see from the back diagram, but just to give you an idea that life isn't so simple that you have high cholesterol and then it causes heart disease. It's much more complex. It's this very complex web of interaction between what's happening at a wider societal level that percolates down, because none of us live in isolation. We live in this broader environment, and all of those factors act on our risk factors that then lead to disease. And it's trying to bring all of these factors together is what is now called as the life course approach. So it's used in different contexts, life course epidemiology, life course public health, and it's ideally defined as it's a study of the long term and these processes that link the social and the behavioral to the individual risk. And not only in one point in life, but at different points in life, from your early childhood all the way to life. And this is the area that I work on, and that's where my research will be focused. And so that brings us with this background to today's talk. And I'm going to talk about 3 studies today. All of those 3 are set in India. And they will actually illustrate 3 different points in the life course to give you that context. One is focused on fetal and childhood life, the second one on the middle age, and the third one is elderly. In some ways, it also represents my own professional life course, because the first study I did was as my PhD. The second one was more of my sort of a postdoc experience, and the third one is more recent one. So it's almost my progression of my life course as an epidemiologist going hand in hand. And I think the third thing to point out here is that you'll see here that all of these 3 studies are examples of low-cost, expedient approaches to conducting research in low-resource income settings. And that's quite critical, because you can't go with the usual norms of study design that you might be doing in a high-income country where you have all the money you want and you have all the settings that you want, and you can just roll in. So almost always you have to innovate. And I hope you see that all these studies are not your classic study designs. You can call them pragmatic or innovative depending on where you come from. But in some ways, that's what it makes working in low-income countries interesting too, rather than working in a high-income setting. So I'll start with the first study, which is about fetal or early programming. And that's how it's defined. It's an event or stimulus that acts at a critical or sensitive period early on in life that leads to a permanent or long-term change in the body system. And you saw that earlier slide when I tried to show you the changes happening in these Korean War veterans. So the idea behind this comes from studies such as this. So there's some data from a study carried out in the town of Uppsala in Sweden. And so what people did was they took a cohort of births which were carried out between 1915 and 1913 in the town of Uppsala, and they had birth weights on these children who were born, and they were followed up subsequently till about now. And what they found was that for people who had the same level of adult risk factors, those who were lower weight at birth had a higher likelihood of having heart disease and diabetes. So imagine that you and I, we smoke the same amount or have the same amount of obesity today. the one of us who was born of low birth weight would probably have a higher chance of getting heart disease or diabetes. And that's quite an interesting idea, and it's been shown in about 100 studies so far. So there's been about 100 studies globally done, where every time you do a study, you find an association between low birth weight and disease later on in life. But what's not very clear is why this happens. One of the most popular hypotheses around this idea of early undernutrition is also called the Barker's hypothesis, or fetal or developmental origin of adult disease hypothesis. To explain it simply, it's also called nutritional forecasting. So it's a bit like if you're trying to go out and you're trying to decide whether you need to be taking a big heavy coat with you or you just need to go out in your t-shirt. You try and look up at the weather and predict, oh, is it going to be sunny today or is it going to be rainy, and you accordingly dress up and then you come out of your house. The same thing apparently happens with a fetus. So when you are a fetus in your mother's womb, you are trying to predict what the nutritional environment will be once you come out. And so if your mother is undernourished, you think, oh, it's all going to be starvation, not enough feed outside. What you do is your body tries to shrink to systems that are much smaller in size. So it's like a thermostat in a fridge, so you turn it down. You turn your body size down, you turn your metabolism down, so you're all prepared for a hot sunny afternoon. You don't come up with many coats on you. And then when you come out, if you get the forecast right, it's great. But if you get it wrong, and that happens a lot nowadays because there's a lot of food about, as we can see outside, you get it wrong, and then it's like a toxin to your body because you planned for a different scenario, and all the extra food leads to conditions like heart disease or diabetes, and that's almost like a toxin to the human body. Now, this is all very good. It sounds very exciting, doesn't it? Very interesting idea, makes a lot of sense. But there isn't much proof, or there wasn't much proof about this to begin with, apart from these hundreds of birth weight studies. I mean, we all know you can be low birth weight for lots of different reasons. In fact, the commonest reason is not poor maternal nutrition in high-income countries, more maternal smoking, for example. So, good idea. A lot of potential because 30% of birth weights in India are low birth weight. So if this was indeed true, we could actually focus our attention on improving birth weight rather than trying to get people to stop smoking afterwards, because things would have been done beforehand. But we need proof before we go down that route and changing our entire policy. So I wanted to find proof for this, and this was my the topic that was really interesting for me when I was doing my PhD. And what I figured was that if there's been enough birth weight studies, I don't want to do the 101st study on birth weight. What would be quite nice is if I could find, and clearly doing a nutrition trial today wouldn't be very feasible, because then I have to wait for the next 20 or 30 years for these people to have any manifestation of heart disease. So I said, what if I could find an old nutrition trial from before somewhere that had been done for other purposes, maybe 20 or 30 or 40 years ago? And what if I could go and find and trace these people today and do a clinical exam on them? Then I'd be able to answer this question, does nutrition in pregnancy really matter? Because then I should be able to see a difference. So that was all well and good. So I went about trying to go to conferences and different meetings and trying to find old birth cohort studies that I might have done in the past. And luckily enough, I did run into somebody at a WHO meeting in 2000 where somebody said, oh yeah, I did a study. It was in late 1980s. I've got all the data. If you can get some money, you can come and follow up the cohort. I said, fine, I'll do that. So I went and got the money, and I'll come to the story in a minute. But this trial that this person was talking about, I just briefly described this old study and the context in which it was done. So in India, we have this program called the ICDS program. It's a community outreach program. It's all a national program which covers about 90% of India today, but when it started off in the late 1970s, the early 80s, it was just being rolled out sequentially. And the point of this program is to give an integrated services for child development, including antenatal services, vaccination, education, and nutrition. But the hallmark of this program is supplemental nutrition. Essentially, there is a local woman appointed in a local health center. All the pregnant women and young children of the village turn up every lunchtime, and she offers them this bowl of nutrition which contains about 500 calories and 20 grams of protein. And that's produced from any local produce that's available. And that's effectively the magnet to get people in. So when this program was being rolled out in the early 1980s, the Indian government was interested in finding out whether this program was, because it was only just started as a pilot study and they wanted to know whether it was making any difference to the population and to the birth weight. So they commissioned a study which was jointly funded by the ICMR and USAID, and the point of the study was that the study was funded to the National Institute of Nutrition, which is based in Hyderabad. Just in the villages around the institution, the program was being rolled out, and some villages had the programs, others not. And they said, oh, why don't we be opportunistic and do a study now between the areas that have a program and the ones that don't, so we can compare the birth weight in the two arms to see whether giving extra food to pregnant moms make a difference to the birth weight of the children. So they got funding for the study. They did a trial following these 30 villages, 15 which had the program in place, 15 that were just waiting for the program to be implemented. They were sort of villages that were adjacent to each other. And they recruited all the births that took place in these 30 villages and found that the ones in the intervention arm were 60 grams heavier than the control arm. It doesn't sound a lot, but actually almost all the trials done so far globally on maternal nutrition supplementation find that this is the level of birth weight difference that you can achieve by giving food. That again raises interesting issues about whether the forecasting hypothesis is right to focus on nutrition or not, because it doesn't seem to change birth weight so much, and so obviously there are other factors that impact on birth weight. So I got a little pediatric fellowship for my PhD, and I turned up in this village to do a follow-up. And this is, I hired a team of about 8 people, some nutritionists, nurses, and we spent about 2 years in these villages in these 2 years in these villages trying to recruit and trace this cohort and follow them up. So we'd go to each village and spend about 2 or 3 months. And then in the first month, we'd go knocking on people's door and trying to find these people. And once, because these were, remember, I only had these old paper records of people's names and other information. I had to find those people. And there's lots of stories about it. I mean, I'll probably see how much time I've got, and Emma will sort of put a hand up if I'm taking too much time. But I'll try and sort of so this is the fieldwork that took on, and we got these different measurements going on, axometry and vesical circumference. So I had these stories here. So either I can tell them now or wait till the end. Now? Okay, Emma says now. So this is more for the students actually, because people who've been in the field probably know about these stories. But I mean, I was doing my PhD, so I was a young buck. I got this little $70,000 or $80,000 fellowship from the Pediatric Royal College, like a travel abroad. So being a boy, I first went away and blew half of it on a very expensive piece of gadget. You know, being a boy, I had to buy some expensive equipment. So it's like an arterial stiffness machine. You put the thing here and it measures your arterial stiffness. So I said, fine, here's my $40,000 gone. So left with $40,000 in my back pocket. I turned up in India, in these villages in Hyderabad, got a little team together and said, fine, let's go and find this cohort, guys. So we turned up in these villages, and first thing I realized when I actually finally got to see those paper records where the data was being held, was actually there was no name for these children. I said, oh, that's interesting, no names, why is that? It turned out that the old study was done before this hypothesis came along, so they had no intention of following up these children. And all they were interested in was to see whether the birth rate was any different. So the child was just number 1 or number 2 based on the birth order. And they were not going to look at those kids again. So they just record the birth rate and put a number. I said, fine, never mind. I'm not going to, it's my PhD. I'm going to work hard. But let me try and find these people again. So I try and find these people. Okay, let me try and find the first couple. So couple number 1, house number 48, village X, Y, and Z. So I try and look for this house number. And then realized, oh, there aren't any house numbers here. What's going on? So it turns out, again, people tell you these things as an afterthought. So it's just a warning to people who are planning younger people who are planning the studies now. So it turned out that when they were doing the old studies, you don't have house numbers in Indian villages, but when they were doing the study, they put like a little notice on each house. They stuck it up with a sticky tape or whatever for the duration of the study. And when the study was over, took it off in the bin, end of story. So there weren't any house numbers either. So here I was, my PhD hanging, only $40,000 left, and I had this cohort to follow up. So I said, let me still keep on trying. So luckily for me, it turned out that these villages weren't so big at that time still. So even though I just had names of these couple, I knew the name of the village, and I realized that if I turned up at a village and asked about who is so-and-so, wife of so-and-so, where do they live, that couple, they live over there. So that was not too bad. I could literally turn up and find the house to begin with. And then there was a little matter of matching these people to the actual index child that I was interested in, not the other 10 siblings that they might have. So I said, okay, I gave the records to my team and said, okay, go and find these people there. So in the beginning, I said, let me go and see how they're doing the job that they are supposed to be doing. So I quickly realized that they were turning up to these parents and saying, that's the child, isn't it? Whichever was sort of one hanging nearby, because obviously, people look for easy way out. So I didn't want to explore too much in detail and say, that's the child, isn't it? And so that child would come in and say, no, that won't do. This is my PhD. It has to be done properly. So I tried to do it in a very scientific, epidemiological way. So I came up with this idea of trying to split my team into two halves. So one half of the team would only be, it's like a blind design. So one half of the team would only go to the field. The other half of the team would only stay at base. Now the team going to the field was not allowed to look at the other information about these children. They would only be given a list of the couples. And what they would have to then do is go to those households, find the couple, and do a full demographic listing and gather as much information as possible about all of their children. So when they were born, all the other information, trying to gather different information. Even that was not so easy because we don't have date of births in this part of India, so you don't have Roman calendar, so you have to try and guess by seasons and the nearest calendar month and the nearest festival. But that worked okay. So one half of the team would collect all the information. The other half of the team would have all the old information from before on a computer. So once they would come back to base with the information, they would put it onto the database, and then we would have a split screen database on the screen. So one with the old and one with the new, and a person not linked to either side would then actually try and match the common information from these two people, from the two sources. And I've created an algorithm to try and do a matching between the nearest dates and nearest pieces of information. And that seemed to me a much more robust way of doing things rather than just saying, it's you, isn't it, who was there in the old study. So that was just one little study, the first one about what house number, what child. Now the second one was actually a very interesting study for me. So when I started this piece of work, I wanted to, like I said, do it very seriously. So when you go around doing these field studies, you take consent from the population. And I realized from the old data that 95% of the population was illiterate, so they didn't speak or read and write. And normally what you do in these circumstances is that you take a piece of paper and get the person to thumbprint. Typically that's what happened in Indian studies. But that to me seemed like a very crude way of doing things, because if the person can't read what they're thumbprinting on, it's not really true to say that they know what they're signing up to. So I went to this big elaborate process of doing it very properly. I got these several dictaphones and I created a computerized database. So I wanted to verbally record what people were agreeing to and what was discussed with them, so it was kosher and nobody would feel what's going on. So we did that, and we turned up in this field, and there were all of these kids, all very smartly dressed up in formal school dresses, many of them speaking fluent English, and there was this one girl here saying, sort of very confidently negotiating with me, oh, I'll participate in your study, but I'm the class topper, I need to be on your time. Only if you agree to drop me to my class afterwards in your study van, that will I agree to participate. And that for me was amazing, because you had this, so remember these kids just 15. You had this parental generation that was all illiterate. In the same population, in about 15 years, an entire generation was there that was educated, confident, looking forward. And just a great sort of insight into how quickly things were changing and how rapidly, at least in some parts of India, not everywhere, that things were changing. So that I thought was a nice story about trying to get a first-hand information about the thing. The last one is a good little sort of, I don't know if people can read this. So when I was doing this field work, because I was based in University of Bristol, and I was spending 2 months in Bristol, 2 months in Hyderabad, going back and forth. And when I was away, I bought them some mobile phones so they could communicate with me by text messages if they had any urgent fieldwork queries. And one day, sitting on my desk in Bristol, I suddenly get this text message. I don't know if people can actually read it clearly. And I've just copied it as it came through. Jalaja Srinivas getting married, seek your blessing, sir. So what had actually happened was that the two field workers I had in my team had fallen in love and decided to get married. And in the typical Indian way, there was a big family hoo-ha, and the parents, because they were a different caste, it always happened in India, and parents wouldn't agree. And so they wanted for me to sanction the wedding. And then they actually had a kid during the field work, which is again one of the productive outcomes of These are just random reflections. Because it's my PhD. When you do a PhD, you get quite emotionally connected to stories. And you have to, like grandparents, you have to get them out to the younger audience whenever they let you speak to you. Okay, so what did we find? Any guesses? I'm looking at the students now. So the idea was, were these people who were supplemented in pregnancy, were they taller? Were they fatter, or did they have lower risk of cardiovascular disease because they had been given, because their moms had been given extra food? What do people think? Go on, be brave.
Yes.
Yes, good. Right answer. So I managed to trace about 1,200 of these kids, which are about half of the actual cohort, and they were aged between 13 and 18. And this is broadly what we found. So the kids who were in the intervention arm, who were also 60 grams heavier at birth, ended up being about 14 millimeters taller at the age of about 15. They were not any more fat than the other arm, which was reassuring, because there's a lot of debate nowadays in food supplementation program whether we should be having these programs because we already have a double burden, and are we going to fuel obesity as a result, which was reassuring. And they did seem to have a low risk of cardiovascular disease, as much as we can predict at this age. So we looked at something called the insulin resistance, which is like the level of insulin you have in your blood, which seems to correlate very well with future risk of diabetes and heart disease, and that was much lower in these kids. Remember the $40,000 that I blew on this fancy machine? That told me that their arteries were 3% lower. For that equates to about 3 years younger, so their vascular age was 3 years younger compared to their chronological age in terms of the artery being flexible. And also their blood pressure was a bit low. So that was all very good, because I managed to get a PhD out of it. So this is just the main publication is out in the BMJ if people want to go and read much more about the study in detail, which is here. And this is just to flag up about, so when people like me who work in these cohort studies, we never stop. So once we find a cohort, we literally got them for life now. So that was a very cheap job on the fly, but then we've got 2 larger pieces of funding to follow up this cohort. The first one, which was called the Hyderabad DEXA study. So I was doing, for obesity, I did simple skin fold measurements, or for arterial surface measurement. But now we've been, in the study, we've just finished, we managed to do very intense phenotyping. So we've done DEXA scans for body composition, we've done catheter scans for arterial vasculature, and lots of other more sophisticated measurements. And now we've actually started to follow the entire household. So this was just the kids first. And now we're recruiting all their siblings and other members in the household. Now I'm just quickly moving from students to colleagues and faculty here for about 2 slides. And that's just to flag up an opportunity for collaboration, so for people to come and speak to me afterwards. So we've got this ongoing cohort study now. It's called ASCAP's Andhra Pradesh Children and Parents Study. This is just a brief description of what we have in mind. So we are right now in phase 1, where we're recruiting the parents and siblings. And remember, there were 1,000 or so people, so average family size of 5. We'll end up with 5,000 members. And we've done about 3,500, 4,000, of this now. So we're coming to just a year left to go for this one. After this, what we have in mind is try to recruit other generations, because we try to work across several generations. And so we're interested in recruiting the other married siblings, the other children who will be born during these cohort members. And in due course, even follow the remaining households in these villages, because remember, we only took these few houses that were part of the study. But these are 30 villages. Some of them are 1,000 people strong, but others are about 40 or 50,000 strong. So there's a population there that could easily exceed 50,000 that could all be recruited. And because the intervention was at a broader level, there is potential there to establish a huge resource that is quite useful for research. And this is some examples of the sort of data we're collecting now. So we've carried on the same protocols as before. So we do the general information, we do DEXA scans and other scans of body composition, we do spirometry, carotid IMT, and we collect fasting bloods and DNA both from the sputum and from the blood. So fairly detailed phenotypic and genotypic profile that we're doing. And so that's just to flag up. So a huge number, as you can see, a huge number of different organizations that got involved in different studies in due course. But there's clearly great opportunities for collaboration here in terms of extending the cohort to other generations and to other households. There's opportunity for greater characterization either from the side of genotyping or epigenetics or phenotyping or metabolomics, anything else that we might want to throw in, or even greater characterization of the environment, for example, because these villages are quite interesting. They're urbanizing very rapidly, and there's potential for looking at how the urban environment and the changing environment is influencing these outcomes. And clearly, the real reason for setting up these core studies tends to be intervention trials, because in the end, proof almost always has to come through intervention studies where either intervention studies done in individuals or across populations. And cohorts like these are great because you've got a captive population that you've documented quite carefully, and then when you try to set up an intervention, you can literally go in and carry out a trial within that framework, and that seems to work well. Okay, so we move on to the second story of the day, which is about the study that we did on urban migration. Now, just a few facts. As many of you know, India is developing very rapidly economically, very rapid GDP growth, huge growth in urban population. And what's very fascinating to me is just this rural to urban migrant number of about 1.5 million every year. So literally, this is the number of people who actually leave their homes in the village every year and move to a city. And that's on a year-on-year basis. And that's being reflected in this huge figure of urbanization. So this is something that we all know. Living in an environment like this doesn't do favors to your waist circumference. It's not exactly here, but I've already found I've been here in Duke for 2 months and I'm finding it difficult to fit into my trousers being around so many calories being freely available. But you can see how quickly these things start to add. And the question then is it all an inevitable penalty of economic development as some people believe? And should we just say, well, tough, as you get richer, you're going to get fatter, end of story? Or should we go down this route as some other people believe, that no, if we understood these wider determinants, we could actually act on them to try and prevent some of these changes or behavioral changes happening in these people, because these are all barriers and facilitators to your own behavior change. And like I said, I find it here. So I used to walk everywhere in London, but here, even when I try to walk from here to my home, there isn't a footpath in half the place, and I have to walk on this mound or the edge of the road, and every time the bus tries to run me over, I think maybe I should take a bus. So the sort of environment you live in does have a big impact on whether you do something or not, and it's not just about your wanting to do something or not. So it's clearly, this is the picture we'd like to get to when you understand this diagram. So, but when you try and get hold of information to support this kind of diagram for migrants, you find that there's hardly any data. Do the students want to say why? Yes?
Because migrants move.
Migrants move, very good. So it's very hard to follow them up. And before that, any other point? So that's clearly a very strong point, that they move, so they're very hard to follow. What else? Because if you want to do a longitudinal study, so if you want to study the effect of migration, you want to have some data on these people before they migrate, and some data on these people after they migrated. Could you easily collect data on people before they migrate? It'd be very hard, wouldn't it? Because only a small proportion of people migrate despite the numbers. And so you'll have to follow a really huge population and then wait for some people to decide to leave, or you could just gently suggest, oh, you want to maybe think about leaving, which is not very polite. But actually, it turns out there's only been one real migration study to date, And that just happened to be because in one of the New Zealand islands, they happened to do a survey in the island, and then suddenly in 1960 there was a big hurricane. And as a result of hurricane, they actually had to airlift a lot of people from those islands to New Zealand. And then somebody took the opportunity of following this cohort again once they moved to New Zealand. So you had both pre and post migration data. But in reality, it's almost impossible to conduct longitudinal studies of migration, which we want to conduct. So remember what I said about trying to be innovative in this setting, and you can't afford to wait too long and have a lot of money. So we racked our brains and came up with this solution, which we've called a sib-pair design. So the idea is this, that imagine that you've got a pair of siblings who are living in a rural environment. And imagine that one person gets one day decides to migrate to live in the city, as like I showed you the 1.5 million people who leave their villages and go to the city. But the other sibling decides to stay in the village itself. Now, if you compare these two people today in terms of their risk factor or disease status, you would imagine that the rural sibling would give you some sense of what this person would have been like had this person not migrated. Because what you're saying is, had this person not migrated, he would have been like this other brother who's still in the village. And so you end up with these sib-pairs who are very similar in their genes because they share half their genes. They're very similar in their early life. Remember the first study I showed you about birth weight and other lifestyle, early life factors, so they all match for those. And so the only difference between a pair of siblings, if one is a migrant, one is not, is this difference of migration. And so you could literally do a cross-sectional study, which is a very cheap study design and very quick study design, and get information like a longitudinal study, which is a very expensive and time-consuming study design. And so this was the plan that we came up with as a way of doing something, again, which I call quick and dirty, to get something that would require a much more difficult way of getting the information. And it's almost like, I see it like a periscope. So you've got a periscope trying to see the person, what the person would have been like before they migrated into the future. And this is a sort of question that we designed, we are trying to answer. You've got different migration issues and changes in lifestyle, and how do they affect. And so trying to get to much more that diagram that I showed you earlier. It isn't just about it's all bad. Are there any factors about migration that we could play around with or mitigate? And there's even been theories about development, for example. So one argument goes that currently the Western model of economic development is you have these big cities where a lot of economies, so people have to move there, and these small rural areas, and they have to migrate often long distances. Could some of these newer developing countries take a different economic approach? So what they do is have decentralized development, so they don't have few big cities, but lots of medium-sized cities, so people have to not migrate so far, if we were convinced that migration for large distance was a big issue. So those kind of ideas that you might try and help these people not change their lifestyle too much. So what we did, again, we found an existing national study that was being done by some of our colleagues across India, where they were doing factory-based studies, taking about 10 or 15 factories across India and looking at risk factors for cardiovascular disease. So we picked 4 of the factories to get a geographical distribution of India from north to south. Then we conducted a survey of all the factory workers in these factories, and we asked them, were you always born in the city, or did you move from a village in your lifetime? So about a third of them said, oh, I moved in the last few years or in my lifetime from a village. I said, great, welcome to us. So we took these people and said, oh, would you like to come to our study, but would you also like to invite one of your siblings who's the closest in age and sex to you to come from the village, so you both come in as a pair? And the incentive there was that we'll pay for your sibling to come and visit you from the village, and you can both have a family holiday, and while you are doing it, could we examine you, please? So we did the sib-pair study, and we managed to recruit about 7,000 participants. And that was quite a good number because people were very skeptical, and half of these people came from 1 or 2 days away from these remote, far-flung villages, having used the bullock cart and train to come all the way. And we ended up with this sib-pair collection, 3,500 sib-pairs who matched with the other life risk factors. And then we did the usual clinical exam in the hospital, like I described earlier, a full standard exam all the way as you might do in a cardiovascular disease study. So what did we find? So I'm going to try and, I've just put up one or two, so we're just still analyzing some of these results now, and I'll just put up one or two results to show you the sort of information that you can get from this kind of a design that you wouldn't get from a standard urban-rural comparison study that you could do. So one of the things we did was that from all of these people, we took a very detailed, because we were trying to create a longitudinal study from a cross-sectional one, we did a very detailed life history of these people. So we asked them, where did you live at each point in your life? What was that place like? Was it a village or a town? What was the house like when you were 10 years old or 50? So almost trying to recreate a longitudinal life story of these people. And from that data, we came up with this kind of a data where we could literally accumulate how many years each person had spent in an urban environment. So what we have so far from literature is just studies where people compare what is the rate of obesity in urban people compared to rural people. What it's not telling us is a bit like, when you do smoking studies, you do studies on life you smoked. So not just asking about are you a smoker or non-smoker, but trying to understand what happens if you're a passive smoker, what happens if you smoke for 20 years compared to if you smoke for 10 years or 5 years. Because literally it's the same story like your lungs. If you're living in an urban environment, there's got to be some sort of a cumulative damage that goes on. That would only come out if you knew the number of years you spent in an urban environment. So this data here shows a couple of risk factors plotted. So on the x-axis you have the number of years spent in the urban environment. So 0 years, 20 years, 40 years, 60 years you might have been living in a town compared to no time, somebody who lived completely in a village. And the first figure is showing plotting BMI or body fat, and the second one is plotting y-axis insulin. And we had a very similar figure for blood pressure too. And what we find is this. So if you look at body fat, you have this two slopes. So what happens is that in the first 10 years of life, all these migrants quickly put on fat, then put on about 3% fat in the first 10 years of life. And then they didn't seem to change very much. So they were only, presumably because they had become very similar to the urban people, they were not becoming any more fatter after the first 10 years of life. So the increase was much gentler, and that's the flatter slope. On the other hand, if you look at blood pressure or insulin, you have this kind of a straight line going on and on till fourth decade of life. So insulin becoming higher by 7% every 10 years, or blood pressure going up by 1 millimeters every 10 years. And that's telling us something very insightful about the biology of how urban migration works. So it's telling us, presumably, that when we first move to an urban environment, the first thing that gets affected is our lifestyle, which leads to the body composition and body fat. And it's only when the body fat has been higher for some time that your blood pressure and insulin effects start to kick in, and it starts a vicious cycle that fat increases your blood pressure, and that goes on and on and on. So if you want to, in terms of what do we know about this, if you want to stop migration effects, you presumably want to focus in the early migrants and their lifestyle when they first move. So you could eventually go to these shanty towns where the migrants first go and live, and try and focus on their lifestyle rather than waiting for things to happen afterwards. And that's just as a way of example. This is just we've published separately on the diet and activity data coming from these studies, and those are out in already published and in press. But I've just tried to put up this slide of something that we're trying to analyze now, and that's a slightly more interesting, sort of different question is about, how clearly when people move to urban environment, their diet changes and their activity changes. But then you could ask the question, which is more important? Clearly both change. But is one more important than the other? So is it 75-25 or 25-75? In which case you might get pointers to focus more on dietary issues or lifestyle issues or activity issues. And this is just some very preliminary data on difference between urban and rural people, trying to give you a sense. So what we find is that they obviously become richer when they move to the urban environment, which is good, because you can't tell them not to become rich, they just to stop from being overweight. Their fat goes up. They start eating about 300 calories more when they move from the rural to the urban environment. Interestingly, fat and oils go up in terms of consumption, but interestingly enough, fruit and veg go up too. Now that's very interesting, because most of us believe eating fruit and vegetable is good for us, is going to stop us getting diabetes and heart disease and obesity. But clearly that's not in play here, because these urban people, because they got richer, they could buy more fat and buy more fruit and veg. And so if fruit and veg, if it has got any role in obesity, it's got to be quite small, because that wasn't stopping them from having all of those problems. And that again is a good argument for doing these research in low-income countries, because again what tends to happen is when you keep doing studies in high-income settings, you do, it's a bit like studies, if you do the study 100 times, you start to believe it. But you forget the fact that all 100 times it was up in the same environment and all the same confounders or the background problems that were in the same setting would exist. Till you go and do a study in a very different setting, your prior assumptions don't get shaken up, and then you have to stop and think, maybe we need more studies in other settings, even to understand the same thing that we think we know much about. And then you've got issues about activity changes and how much TV people watch. And this is just to illustrate some examples of data that you get. Now, coming to the most exciting of all, and something that's closest to my heart at least, which is the study of yoga. So, yoga is an important part of my life, and I've always been very interested in yoga. I've always gone on yoga retreats, and I've always dreamt of doing a yoga study. And you're slightly wary of trying to spend a lot of time trying to write grant proposals to fund something like a yoga study, because you know that your peers in the peer review process won't look very kindly at it. And you either try to make it too sort of holistic, in which case it just goes in the bin because it's not reductionist enough for our Western mindsets, or you make it very reductionist that you actually lose the whole point of yoga and it becomes like Pilates or something else. So it is a very fine balance that you have to try and tread, because if these therapies need to be integrated into the usual therapies, we obviously need to get more scientific evidence for them, but they need to be approached in a much more, with a slightly different paradigm rather than the standard reductionist medical paradigm of medical research. So, just as sort of starters, you can see yoga has always been a very important part of Indian lifestyle, from ancient India to current day schools. I had these sort of school classes where we sort of sat in a group and did some yoga. And clearly it's a poster boy or poster girl for many of the ad campaigns that draw people to India. And it's obviously been making some headlines even in the Western press and literature over time. So I came into it through cardiac rehab, and again, I shouldn't tell you this, but like I said, I always wanted to do a study on yoga, and I was wary about trying to write a grant. And then last year, the UK Medical Research Council, is like the NIH for the UK, paired up with the Indian Medical Research Council called the ICMR, and they came up with this plan that they wanted to fund a few studies jointly, just as a relationship building exercise. So they were both going to put money. And they asked for calls for studies that would address some practical problem, but would require studies to be done in both settings. So that was the requirement. And so people were encouraged to come up with study designs or studies that would have a practical implementation, but could be done doing simultaneous research both in UK and India. And I said, that's a good way. I'm sure if I do something on yoga, they'll buy it, because that's something in a panel of India, UK, in the spirit of India, UK collaboration, more spiritually speaking even, it's got to work. So I thought of ideas and came up with this idea of cardiac rehabilitation. For people who are not familiar, cardiac rehabilitation is, when you have a heart attack, it's the process of recovery, and you facilitate that recovery by having generally a series of sessions that you go to a clinic, or people come to your house. Normally go to a clinic for a number of sessions where you are put through some exercise and educational sessions to help you quicken that recovery process and stop you getting from the next heart attack and other things happening. And it's a very well accepted concept. You have a cardiac rehabilitation program here in Duke, for example, and there's been about 30 or 40 odd studies done globally, on huge trials done on cardiac rehabilitation, and they all find amazing effects. About 25% reduction in mortality, which is huge. That's much more than any medicine that you can give, and that's just by people coming to these few sessions over the first few months after your heart attack, where you get a bit of exercise training, get a bit of education about your lifestyle and other stuff. And that seems to be work amazingly well. But what tends to happen is the Western model of cardiac rehabilitation involves these large teams, multidisciplinary teams, nutritionists, activity people, cardiologists, nurses, and these kind of heavily kitted environments where you have to go to this big setup where you have all of these kind of things. Now clearly, cardiac rehab is a great idea, would be very helpful, but it's not really a realistic option if you're thinking scalable India. So there's clearly these very expensive few hospitals that few people go to and they could have it. But if you're talking of something across the board in India, where you have these very poor hospitals, they're not going to invest in those heavy programs, and there's not going to be money fund for that in any time soon, and it won't happen in this kind of setup. So I propose this model for yoga to be like a potential solution. If you look very carefully between these two wheels, so one on the right hand side is what a cardiac rehab. So if you went to a cardiac rehab class, you spend maybe an hour doing a lot of exercises, and then the last half an hour would be spent on either giving you some sort of psychological. Remember, if you have a heart attack, you're very distressed and you're trying to reevaluate life, and you're mentally very stressed out. So you get a lot of counseling and even cognitive behavioral therapies, and probably even drugs if you need for depression and things. And then you also get a lot of advice on how to change your lifestyle, your smoking cessation treatment, or your nutrition counseling, and all the other things that go with it. And that's what a rehabilitation program does. I don't know if any, for the ones amongst you who've been to a yoga class, it might remind you very much of what a yoga class looks like, or it should look like. I mean, I know in a lot of the Western yoga classes, it tends to be a lot more focused on just the exercise part, and there's not much conversation that goes on. But if you went to a slightly more traditional yoga class, you would actually have the same balance, that there would be half of exercise and half of discussion and conversation. And the exercise would be the yoga poses. Then you have a lot of breath control and meditation and relaxation that gets thrown in to calm you down and to act on your mental health. And then a lot of the yogic principles, when you talk about those principles, they are actually about lifestyle. So they're about living a life of self-restraint. So don't smoke, don't drink, sleep on time, do all the right good stuff, which is also what we do in rehab. And also have a vegetarian diet, which you may or may not buy off. So clearly there's a potential there for something, if it works, to be affordable, scalable, culturally appropriate for a setting in India. All you need is one yoga teacher in each of the hospitals, which is much more sellable to each of those hospitals in India than would be to turn up and say, oh, we'd like to have a 12-member rehab team in each of those hospitals. So these are just some diagrams. I mean, these are just some figures to suggest the upstream and downstream mechanisms for yoga to work. These are some of the ideas that might work more in sort of upstream way. And this is a very complex diagram. You don't have to read it carefully, but there's been lots of studies done on these neuroendocrine autonomic pathways. So the thing with yoga, as well as a lot of integrated medicine, is that if you look at the literature search, you'll find about 100 studies tomorrow. But they've all been done on 20 or 30 people for these intermediate risk factors. So you might measure somebody's neuroendocrine pathway, or you might measure a vascular change or some hormonal level. But nobody does real solid studies that would convince funders and policymakers. So there's a lot of research of this level existing. So what we proposed, and that's the study that actually, it just got funded a few months ago, and we're in the planning stages of this study, is to develop a yoga-based cardiac rehabilitation package. So we will literally say that we are producing, like you would, a rehabilitation program, same kind of a session and things, but all the ideas in it will come from yoga. So it will all be yogic elements of exercises or lifestyle advice and stuff. And so what we said was, in the first phase, we'll spend about 6 or 9 months developing an intervention, like a rehab package that uses yogic principles. And we'll do that by reviewing scientific as well as yogic literature. And the intervention will be deliverable through yoga teachers. And then we'll conduct 2 trials. One trial will be a clinical trial in India, so it'll be a very hard outcome, regular clinical trial, 4,000 heart attack patients done nationally across 16 centers in India for a real hard outcome of mortality and cardiac events at age 1 year. So if it works and we can show mortality reduction, there'll be huge pressure on all the funders to fund it, because that will be a definitive study on yoga. And then for a complementary study, we'll conduct a smaller 80 people trial in the UK, but that will be much more looking at the earlier diagram about the mechanism. So this will be in a very high-end lab looking at neuroendocrine pathways and cardiovascular physiology. Because when you work on these kind of fields, even if you've got to do both things for these kind of integrated medicines to get really integrated, you've got to show hard benefit, but you also got to come up with scientific rationale for these things might work. Otherwise, it's too soft for some people to take on board. So this hopefully will provide, if it works, both clinical outcome data as well as a mechanistic data that people can actually accept or reject at that point. And that's what we're about to start now. So I think that brings me to the end of my talk, and I'd like to finish with these words from Emerson, which I think probably go in all of these studies that I've tried to show you. And probably when I looked at this heading, I said, did he actually mean trail or did he actually mean a clinical trial? But that's for you guys to decide. Thank you.
Sanjay, can you control for yoga?
We've actually, in both the arms...
I mean, do people who do yoga do it all the same? So that you really be able to differentiate the effect? The yoga experts in the room, does yoga mean the same to everybody?
Yoga would mean different things to different people. In fact, the first 1 year phase of development is precise, our belief, and I think a lot of good yoga people will believe, that even though it might have different exercise and different things, the traditional yoga is more or less the same and probably would have the same effect, the way it works in terms of mental pathways and stress reduction. And the reason we have this 1 year development phase is not because we think that exercises have different effects. It's just to standardize so we can sell it afterwards, because people like you, Mike, will afterwards say, oh, what about this other type of yoga then? So we are actually literally going through that process to have a buy-in, that we actually did it in a rigorous way. We looked at the yogi literature, we looked at the scientific literature, only to standardize the intervention, not because we believe it's got different effect, but just so that we would have gone through the motions of having done something that's standard. I don't know, other yoga people, I think a lot of people in the room do yoga, I don't know if people think they have different effects, but my view would be that it's all the same.
Sanjay, you also mentioned that there are 4,000 patients across 16 centers. Are patients within each center being randomized into?
So it's individual randomization, not center randomization, and there will be a controlled arm, will be enhanced usual care. So currently there isn't any rehab in India,
right,
but we will provide them a 3-session educational program as a version of enhanced standard care, so they'll get some advice.
And do you worry about contamination in that case? Because you would expect that the same nurse that treats the patient with the routine care is also going to be directing the patient into the yoga, and then they'll start. There's a lot of.
Oh, we'll have a 3-member team in each center, and there'll be sort of blinded elements. So there'll be an element that will just be doing assessments. And luckily for us in this trial, the hard outcome is death. So it's be very hard to have any bias in the outcome because somebody's.
Well, no, I was worried more about the exposure in that. I as the nurse in the normal routine clinic might notice that the guys who are actually being in the yoga trials are being advised about lifestyle changes and stuff, and I start doing that as well. So
I think that would happen to an extent, but that's part of it. What they wouldn't get is our formal intervention package. So what will normally happen is normally in the poor government in the hospitals, you have your MI, you get your treatment, you get sent home, and the doctor might see you again in 3 or 4 months' time. Right. And most random people who walking into the emergency ward won't actually necessarily have much to do with other people who are in the ward, so they would have their own care. Right. And we will call them back. We'll randomize them, call them back separately. Some into the yoga class arm, which will have these sessions spread over 3 months, and the control arm. Like you say, the control arm, if they want to, if they hear about it, can go and get yoga somewhere. But that's part of it.
That in some sense, I think, is, tying back to Mike's question is, if the intervention on the yoga arm is much more intense in terms of the amount of interaction and the human resources that you put into it, can you effectively control for that in the control arm? Can you basically say just the amount of time that the providers spend with them is a big predictor?
That will be an issue, and we will be spending about there will be 3 sessions versus 13 sessions, so they are getting some inputs, and it's reasonable. The other thing to point out is that there have been lots of real controlled trials of rehab,
right,
and they've shown 25% reduction.
Right.
So if we can show 25% reduction, then
it's just as good.
It doesn't really matter whether it's contact or anything else. I mean, it's coming through a yoga teacher. And we will also do cost effectiveness analysis and other things. So in some ways, it's almost like you're right, it's quite possible that having something works.
Right.
But if it works to a good extent and it's very cheap,
Right.
then we'll argue for it to be introduced without worrying too much about necessarily the science. And there is the complementary study that will also inform us. Yes.
Could you comment on controlling for medical therapy? One center being able to provide aspirin, ACE inhibitor, or toprolol, another center not being able to provide, or patients can't afford to get medical therapy?
So the randomization will be stratified within center. So in each center, if they recruit whatever number of patients, every patient would get the same clinical care. And within that center, patient will be randomized to intervention or control. So it will be within center. So they won't be, so we're randomizing stratified by center.
Can I ask one last question? I don't mean to monopolize, but so in terms of the randomizing the patients into the yoga group, I would expect that take-up would be very different all over. So basically, there'll be a lot of attrition you can expect because, if you ask my mother, for example, to sign up for a yoga class, she will not.
Yes.
And so that is going to be hard for you when you're trying to achieve that sample size and balance across the two arms, right?
Yeah, I mean, that's something we haven't faced now. United might come up. I mean, we're hopeful that it's being done in India, the big trial. So there is a certain amount of susceptibility in India to yoga. So we hope that, I mean, clearly in any trial, there will be some amount of loss. You also hope that people who have just had a heart attack would potentially be much more compliant. So a lot of the rehab trials have substantial take-up at least in trial arm because they've just had a heart attack. If somebody is willing to talk to them or offer them some advice,
that's true.
People will sometimes make an effort. And being in India, we think it may not be too bad, but we have to see how it goes.